Welcome students, my name is Naomi James. I am a certified post-anesthesia nurse, and throughout this presentation I'm going to present an unfolding case study on acute cholelithiasis. This case study was intended for the educational purposes of a newly registered licensed nurse who is participating in a perioperative department. Throughout the presentation, the nurse needs to understand the etiology and pathogenesis of the disease process related to cholelithiasis, examine the medical history and risk factors, implement a very detailed review of systems and an adequate physical assessment for the patient, understand how to analyze key patient data during the physical exam and the review of systems, select appropriate nursing interventions, evaluate patient understanding, and of course create a nursing diagnosis and care plan for the patient in this case study. The patient presented in this case is Mrs. Rivera. She is a 46-year-old Hispanic female and she has been diagnosed with cholelithiasis. She's scheduled to have a laparoscopic cholecystectomy, and during her preoperative interview she is presenting with a chief complaint of abdominal pain and nausea after meals. We will use Mrs. Rivera as an example of how to unfold a proper case and do proper perioperative care for a patient that is experiencing acute gallstone inflammation. Alright, so let's jump right into the background and the description of illness. Cholelithiasis is the formation of calculous gallstones, and those gallstones are a result of some type of inflammation and irritation caused to the gallbladder. And that inflammation can be caused by multiple different things. Just to list a few, it can be caused by edema, some type of infection, or impaired circulation. So if you look here to the picture to the right, you'll see the gallbladder, this green organ. It sits right under the right lobe of the liver. And the primary function of the gallbladder is to store bile. And that bile is concentrated, and then when it's needed, it's released into the small intestine. So for example, if you eat food that is high in fat or high in cholesterol, that bile is used to emulsify that fat and break it down properly. However, when you have some type of inflammation or any type of irritation to the gallbladder, it's not able to do its function. And sometimes it'll even overfunction, so it might over-secrete too much bile, it might not secrete enough bile, the bile may become over-concentrated, and all of those factors will result in the bile calcifying and hardening and turning into little stones of bile matter. One of the worst things that can happen, if you look back over to the picture, is that those stones will form over here in this little slender bile duct, and if those stones harden and get caught into that bile duct in any way and obstruct it, you can have cholecystitis, you can have a lot of other gallbladder complications. So right now the patient has a surplus of gallstones most likely, and that's why she's presenting with those symptoms, and we'll learn about that as we go throughout the presentation. In discussion of the pathophysiology of the disease process, the gallbladder is responsible for housing and regulating a lot of different substances to include bile, calcium, cholesterol, and other proteins. Therefore, the exact etiology of gallstone formation is still not clearly understood. We do know that individuals that create and secrete more cholesterol into their bile are more likely to form cholelithiasis over time, and that if they have any impaired motility or circulation to the gallbladder, that it can cause bile to be trapped and reabsorbed and used inappropriately, along with any other metabolic substances of the gallbladder. Also, we have learned throughout research that there is a prevalence in finding H. pylori to be a pathogenic agent in many patients with chronic gastric diseases, especially in westernized countries. And many patients with chronic cholelithiasis do have a history of H. pylori, or H. pylori is found in the discovered stones. So as far as the pathogenesis, the patient needs to understand that genetic factors play a heavy role as far as a family history with gastritis or any type of gastrointestinal disorders. Family history of high cholesterol and any gallbladder complications also increase their risk to experiencing this disease over time. Now we can discuss Ms. Rivera's medical history. In her medical history, it's noted that she is a type 2 diabetic. She's non-insulin dependent. She has hypertension, obesity, and GERD. These are all red flags associated with her disease process that we will learn as we go on throughout the case. Her surgical history, she has had a colonoscopy and an EGD in the past. She had 4 C-sections, a carpal tunnel repair, and she notes that she didn't have any anesthetic complications. Her family and social history, she has some type of alcohol use daily. She's a non-smoker. She's married and lives with her pets. She's a private caterer and a small business owner. Her father has a history of alcohol abuse. He's a diabetic and has hypertension. Also, her mother is obese and has hypertension, GERD, and stomach ulcers. So in this very brief medical history, we can see how Mrs. Rivera's social and family history play a direct part on her medical history. And we will learn later throughout the presentation how all of these factors are directly affecting her disease process. A thorough family history is imperative to an effective medical history of a patient. And it's really good if you have the time to sit with the patient and get some family history going back to a second or a third generation. If you look at this family pedigree of Miss Rivera, you can see a lot of medical similarities in her family, and I'm going to begin to highlight a few that are also prevalent in her history as well. And it really just plays a role, a key role in how we understand the genetic effects of family issues related to the disease process and lifestyle choices of a patient. So I've highlighted a lot of things that they have in common, and it's just funny how when we have the time to really get a good understanding of the background and the timeline of a patient, you can sit down and on paper and see, okay, now I understand how these certain issues and comorbidities have played a role in this patient's life. It's part of their genealogy. From alcohol abuse to obesity to hypertension, there are just certain things that most likely Miss Rivera was going to not be able to escape according to the genetic factors that play a distinct role on the disease process of our patients. Now for a critical thinking moment. Looking over the patient's family pedigree and Mrs. Rivera's medical history, which significant factors do you believe increase her risk for cholelithiasis? And I'll give you some time to think about it. Mrs. Rivera has a lot of risk factors that make her susceptible to experience acute cholelithiasis. According to QSIN, the Quality, Safety, and Education for Nurses organization, there are 4 acute and common risk factors associated with gallstone formation that are called the 4 Fs. And that is if the patient is female, 40, fat, or fertile. And Mrs. Rivera fits into all of these criteria. She is female and she's Hispanic American, so that increases her risk. She's a woman over the age of 40, and typically women ages 20 to 60 are twice as likely to develop gallstones, so she does fit that risk factor. She is obese and she's a diabetic, so another risk factor that she has. And then fertility, we know that she's been pregnant 4 times, so definitely at one point in her life she was fertile, and she's not menopausal, so she would still be considered a fertile woman. So we also know that this risk factor applies to her as well. Some other risk factors for patients that you can explain to your patient is any prolonged fasting or rapid weight loss, diseases such as Crohn's disease or sickle cell disease, glucose intolerance, having high cholesterol, being on cholesterol-lowering drugs, family history and genetics of gallstones, and gastric bypass surgery. All of these risk factors make a patient more susceptible to acquiring gallstones, and it is good to make sure that you discuss these risk factors with the patient so that way they understand how they were more susceptible to acquire this disease. Now we can take a moment to review her history and review systems. So Mrs. Rivera takes a couple of medications to include a multivitamin, metformin, and ibuprofen, as well as Zantac and omeprazole. And according to her disease process, some medications that may be affecting her gallbladder could be her ibuprofen because it's decreasing her inflammation, and also any medications for GERD and metformin can increase her risk to having issues with her gallbladder. As well as we see that she has hypertension, which shows that she has impaired circulatory and cardiovascular issues. And we don't know if her hypertension is well controlled, so it definitely could be contributing or has contributed to her gallbladder complications in the past. Also, she was anemic at one point, and her anemia could heavily have affected her liver function, gallbladder function, pancreatic function, or all of the organs of her biliary system. Therefore, it's good to highlight that to know how some of these systems that we review with a patient and their medication history can help us to understand their disease process. Upon further review of Mrs. Rivera's systems and getting more of her subjective report, we see that her skin is within normal limits. We go on to her gastrointestinal and her liver function, and we find that she has epigastric pain after meals, abdominal pain, bloating, and flatulence. And these are all subjective findings to highlight because they play a huge role in her disease process that is going on right now with her gallbladder. Also, in her renal function is normal. Hematologically, she has anemia in the past, which was already noted. She has some neuro and psych disturbances, very mild, nothing to heavily report. In her endocrine and metabolic findings, we talk about her diabetes. She's on oral medication, however, she's obese. And her HbA1c level is within normal limits, so her diabetes is well controlled. However, we need to understand that any patient with any pancreatic dysfunction, to include diabetes, puts them at a more increased risk to have complications with their gallbladder, and she of course does fit into this description. Her immunology and she has seasonal allergies. She uses Flonase. Nothing to report in her genitourinary system or musculoskeletal system. Her gynecological history you can briefly discuss. It doesn't have a direct effect on her cholelithiasis other than the fact of being a risk factor. You can see that she's been pregnant 5 times and she had 4 live births. So at one point she was very fertile, and fertility is a huge risk factor for patients with gallbladder dysfunction. The next portion of the case study is about the physical assessment, and this is the time where we can get that objective description of what is going on with Mrs. Rivera's body and her disease process, and we can get some thorough hands-on data. So you're always going to start with an admission height and a weight, so that way you know where she stands from there. Then you're going to assess your vitals, and just looking at her vital signs, there aren't many red flags other than her blood pressure and that borderline temperature, right? That's a little febrile. So those are 2 things that you definitely want to note and you want to report, because that's not, typical or normal for a patient at this time. Going on to her neurological status, most likely she should be alert and oriented ×3. We've been having a full disclosure and discussion with her. Probably nothing to really physically assess or report that's without of normal limits with her neurological status. Her respiratory and cardiovascular are also normal, so you hear S1, S2 sound. She's got good pulses. Cardiovascular wise, respiratory, her lungs are clear. She's able to breathe unlabored. So now we can move on to what we really want to discuss, and what we really want to assess is her abdomen. And this focused assessment should be quite thorough. You want to definitely take a good look at her stomach. You want to listen to her stomach. You want to touch it. You want to see all of what's going on. And from that assessment, you see that she has right upper quadrant tenderness and pain, especially during palpation. You see that her abdomen is rounded and distended, and that could have to do with obesity, or it could be directly related to her gallstone inflammation. When you go to her extremities, she has full range of motion. She does report that chronic lower back pain again, so hopefully at this point of the interview and the physical assessment, we've already noted and put into the chart where that pain originated from. And then we can go to her skin assessment, which was within normal limits, and there's no discoloration and nothing too heavily to be noted. So we're going to move on to how we're really going to do a good focused abdominal assessment for any patient presenting with gastrointestinal disorder, especially with cholelithiasis. A focused abdominal assessment is very important for a patient that is having any type of gastrointestinal disorder or disease process. Mrs. Rivera is presenting with a positive Murphy sign according to her previous assessment. And a positive Murphy sign is basically when you are doing your palpation and you ask the patient to take a deep breath while you're touching their belly, especially in the right upper quadrant, and their pain is intensified as you're pressing down. Typically, a Murphy sign is visible or presented in a patient that has acute cholecystitis, which means that those gallstones have become inflamed, infected, or they have obstructed parts of the gastrointestinal system. Even though this is not confirmed in Mrs. Rivera's case, there are many patients that present with acute cholelithiasis that also can present with a positive Murphy sign. And it is an indication that intervention is not only necessary but imperative to make sure that complications do not arise. So you want to ensure that you ask your patient to describe the pain, to include the intensity, and what precipitates the pain to intensify. Going back to our basic nursing knowledge of an abdominal assessment, you want to start with inspecting the appearance of the stomach, taking a very good visual look at it. You want to listen for bowel sounds, and you should expect that the bowel sounds will most likely be hyperactive in a patient that has acute gallstone inflammation. You want to percuss so that way you know the proper placement of the organs, especially the liver, and you want to palpate, touch the tenderness, determine the exact location of discomfort, and make sure that you ask the patient to be as descriptive as possible so that way you understand all of the elements of their pain in their abdomen. It's time for a pop quiz. After performing a review of systems and physical assessment of Mrs. Rivera, the nurse notes new orders from the physician for the patient to have preoperative labs performed. The nurse understands that the physician ordered a serum AST level to determine which diagnostic assessment. A. Assessment of gallstone location. B. Confirmation of decreased pancreatic function. C. Determination of the type of stone. Or D. Indication of decreased liver function. And I'll give you a couple of seconds to think about it. All right, now it's time to find out the correct answer. Congratulations! D is the correct answer, indication of decreased liver function, and that is because a liver panel is typically going to be ordered on any patient that is presenting with gallbladder symptoms. The serum AST level will indicate to the surgeon if there is any irregularities or injury directly caused to the liver that is related to any complications with the gallbladder. Mrs. Rivera has a confirmed diagnosis of acute cholelithiasis, so she probably has already had specific lab tests and diagnostic tests completed. However, whenever a patient is scheduled to have surgery, many times you will see that the surgeon will reorder certain labs and he will reorder certain diagnostic tests in order to confirm the most current and accurate updated presentation of the patient's disease process. So Ms. Rivera will definitely have a CBC, a liver panel, and a bilirubin level drawn, and this will help the surgeon once again to make sure that there isn't any liver injury or pancreatic injury related to complications with her gallbladder. The CBC will give a baseline of her blood work and make sure that she isn't anemic and isn't going to have any anemic episodes during surgery. The hallmark diagnostic test is an abdominal ultrasound or an x-ray, so that way the surgeon can visualize where the gallbladder is located and exactly how many stones there are in the gallbladder and where the stones are located as well. If for some reason that abdominal x-ray or ultrasound is inconclusive, then the surgeon may order a more advanced CT scan or MRI of the abdomen in order to give a more thorough visual representation of what is going on with the patient's disease process. Mrs. Rivera's clinical findings and her lab values have been reported. So when we look through her CBC, we can see that her levels are normal. There's nothing to be reported. So most likely her low-grade fever may be attributed to a possible infection that hasn't spiked yet. And also her anemia, like she said, was in her past history and obviously has been resolved or controlled. As far as her liver function tests, which are very important for the surgeon to know if she's had any injury to her liver, her serum ALT is a little above normal. Her AST is within normal. Her ALP is elevated. Her albumin is normal. Her total protein is right on borderline, and her total bilirubin is elevated as well. So she may have some liver injury due to her gallbladder inflammation and her gallstone formation, and this is important for the surgeon to understand what all is going on with her disease process. Her pregnancy test is negative. Her glucose is 109, which means that she does have good diabetic control, and her cholesterol is increased, which is a typical finding for most patients that have cholelithiasis. So that also indicates that most likely her gallstones are formed from cholesterol and a heavy cholesterol production, and the surgeon may definitely want to control her cholesterol after surgery to make sure that they prevent any future formation of gallstones. Now for another critical thinking moment. What are some appropriate nursing diagnoses for a patient presenting with acute cholelithiasis? And I'll give you some time to think about it. The patient-centered care plan for this case study is complete with 3 nursing diagnoses to include acute pain, meal intolerance, and risk for postoperative nausea and vomiting. The nursing diagnoses are related to Mrs. Rivera's gastric inflammation and her medical history, as well as being evidenced by her subjective and objective reports that were found during physical assessment to include her abdominal pain, tenderness, and any other findings. Her plan and outcome are very simple: patient comfort, education and teaching, and addressing pain. And these are all appropriate to make a concise patient-centered care plan for any patient with acute cholelithiasis. Mrs. Rivera has 2 routes of treatment in order to address her acute cholelithiasis. If she chooses medical treatment, she will take oral bile acids, and a well-known one is called UDCA or ursodiol, and it is used to dissolve cholesterol-formed stones, which are basically soft stones that are non-calcified. Typically, the stones will return over time, especially if they're not soft enough for the oral bile acid to break down. Therefore, we will encourage Mrs. Rivera that the best thing to do is to stick with her surgical plan. Surgical treatment is still the gold standard for any patient that has symptoms of gallbladder inflammation, and it will allow the surgeon to properly remove all of the stones and possibly remove the gallbladder if necessary. Now, if Mrs. Rivera is still not comfortable with having her gallbladder completely removed, the surgeon may opt for her to have what is called lithotripsy, in which a shock wave is administered to the gallbladder in order to break up those very large stones and crush them into small little pieces that are more easily to be removed laparoscopically, or to put her on oral bile acid later and dissolve the soft stones now that they were properly broken up. Health promotion and nursing interventions listed in this case study are related to the two modes of treatment. If Mrs. Rivera were to be on medical treatment, we would ensure that she had proper medication, education, and instruction about the use of URSO. She will need to know that this is a lengthy treatment that can take 3 to 6 months depending on the physician's prescription. She'll need to know the common side effects of the medication and that she will have multiple follow-up visits to include physical examination and liver function tests. Also, we will need to promote that she continue to be on a healthy diet regimen in which she is eliminating high-fat foods and eliminating foods that are high in cholesterol and sodium. If she continues with her surgical route, she will need a consult to anesthesia for evaluation immediately, especially according to her medical history and other comorbidities. We need to witness and support her informed consent to make sure that she thoroughly understands the surgical procedure she is consenting to. She will need preoperative education to include any postoperative complications, her risk, and to educate her on what she will expect to happen after her surgery, as well as instructing her on diabetic and hypertensive management to prepare her for surgery. Mrs. Rivera has decided to consent to surgery, and we want to ensure that her medical chart is heavily reviewed. We need to ensure that there's a complete medical history and a review of systems on board, that we have a physical assessment that has a heavily focused abdominal assessment. All of our completed lab work and diagnostic tests should be resulted in her chart as well. There should be a documented care plan with appropriate nursing diagnosis and nursing interventions that include any patient education that was provided throughout the interview. Before concluding the case study, I want to go over some important facts to remember. Any patient having acute cholelithiasis is experiencing inflammation to the gallbladder that is resulting in gallstones. Also note the 4 F's of acute risk factors, which is female, 40, fertile, and fat. Always complete a very thorough medical history and a review of systems. Your physical examination should focus on an abdominal assessment. A liver panel and an abdominal ultrasound are hallmark diagnostic tests to confirm the extent of the patient's acuity, and make sure that your care plan is tailored to meet the specific treatment options for the patient that is experiencing inflammation of the gallbladder. This concludes the case study. I hope that you enjoyed the presentation and that you were able to learn some very useful information about how to properly surgically prepare a patient that is experiencing acute cholelithiasis and that is expected to have a laparoscopic cholecystectomy. Thank you for your time.